We're going to go in order here. They oblige me by sitting right in line. These guys are just awesome. So
to medical school.
Yes. My colleagues here, all physicians, and all are leaders in their respective areas, and just I'm so honored to have them here on this panel. Brian Clay, he's the Chief Medical Information Officer for both Inpatient and Hospital Affiliations, and a Professor of Medicine at UC San Diego. Next to him is Rick Peters. He's the Chief Technology Innovation Officer, which I really like that title. I'd have to figure that one in. At the Dell Medical School at University of Texas, Austin. He's got some interesting perspective on setting up a new medical school. I think it's awesome. And we'll get some interesting thoughts. Next to him is Neil Solomon. He's the co-founder and CMO of MedZed. And they focus really in telemedicine, really and he's going to talk a little bit more about specifically the telemedicine for the high-risk folks. And then last but not least is Peter Tippett. He's the founder and CEO, among many, many other things, which we'll probably dive into a little bit in his background, of Health Accelerate. And they really are looking to provide a secure, cloud-based mechanism for people to share, actually providers to share medical information. So today we're going to really be talking about next generation healthcare and try to get our thoughts of where is healthcare going. And what I'm going to first do is just have each of them introduce themselves and maybe talk a little bit about something they're working on of interest. And then I've got sort of a philosophical question to throw their way and see what they come up with. So Brian, you want to introduce?
Thank you, Todd. So I'm Brian Clay. I'm an internal medicine physician at UC San Diego. I'm a hospitalist in my clinical work, and I serve as the Chief Medical Information Officer there. One of the things that we at UCSD are looking to do is to try and start to operationalize the concept of a learning health system. It's a term that gets used a lot and tossed around as kind of the thing we're all looking toward. But we're looking to actually take a lot of the data that's in our electronic health record and other systems and use it to glean insights about clinical questions that maybe specified research hasn't been done or other inquiry hasn't been made to try to help care at the point of care for our clinicians.
And Rick Peters, I'm an emergency physician in training, but I'm primarily at Dell Medical School, which is a brand new medical school, sort of greenfield in terms of anything we do from education through technology to clinical practice. My focus is on technology innovation there, hence the title. The three key things that we looked at clinical practice, we're trying to do integrated practice units, so really provide cross-disciplinary care in our clinics and take that into the hospital, into the aftercare as well. In terms of our medical informatics side, it's really on digital diagnostics and digital therapeutics, really looking at what we can do in terms of discovering new ways to look at imaging and things like that relative to care. And then on the pure informatics side, we're looking at social determinants of health. And what we state, instead of big data, we're the little data shop. We want less data of higher quality and greater computability. And we're trying to figure out how to do that from workflow all the way through to decision support and machine learning.
Hi, Neil Solomon. I'm an internal medicine doctor. I'm the Chief Medical Officer of a company called MedZed. We take care of frail, high-risk, and post-discharge patients in their homes using a 21st century house calls model. Very difficult to ask doctors to spend half of their day driving around to people's homes. Very few want to do that. And in a typical day, they could see maybe a half dozen at most. So you can't really scale that to the needs of the community. So we have a novel model where we have a legion of nurses in the community who see patients, bring with them a mobile telemedicine unit that they use to link back to one of our primary care providers. So our PCPs and our nurses treat the patients in tandem, and we do a lot of social services as well. So we're very focused on the social determinants as well as the medical stuff. And I practice on that platform now, so I'm happy to talk more about that later. But I would say in this illustrious line of big thinkers, I am the low-tech guy here. While we were doing telemedicine, and that sounds cool, really what we're doing is bread and butter for people who otherwise wouldn't get care.
Well, telemedicine in the end is just drop the tele. It's just medicine next to it, right? It's, I'm Peter Tippett. I was I did an MD PhD and wound up as a computer security technology company guy with the Norton Antivirus was me and several other computer companies along the way. Lately I started a company called Health Accelerate and it relates to the problem that only 4% of doctors in America can get a medical record to a random doctor outside of their own facility and keep it digital. Patients are completely aware of this because all of us who help our moms or sisters or whoever else who have a record in 3 or 4 places try and get it all together to make it useful, find that nearly impossible. And doctors are upset. Doctors just want the answer. They just want to talk. When you think about medicine, it's a knowledge profession, right? And in all other knowledge professions, we work to enhance communication. All of the knowledge professions work to enhance the knowledge workers communicating with each other and getting more and more data, being able to query each other and get thoughts and concepts from each other. But in medicine, we haven't even had the PC revolution yet. If somebody has, the personal isn't there although we use PCs, we don't use them for anything other than getting at the sort of mainframe model, monolithic, EMR. And so Healthcelerate is trying to solve that problem by producing a system that is over the top. It allows any clinician to get a medical record to any other clinician from any EMR to any other EMR without any help from any CIO anywhere. And it's also free for the recipient. So this is like Gmail, and you can send messages, but any size record you want. An MRI would be fine. Texting like Snapchat, secure and compliant and all that, but to anybody in the country that's also a clinician. And Dropbox sort of models, all combined so that you can also look at the medical records and view them and share them and get the medical permissioning right. And so getting HIPAA and all the rest correct is hard. But once that's done and it's now shipping, we feel like we can be an adjunct to all these other things. And all the stuff we've talked about for the last day and a half here boiled down to dealing with data. And if 90% of all faxes in America are done in healthcare, we've got one customer in one building in one city in California that does 20,000 faxes a day. And those faxes mostly go to other doctors in the same building, just because they've got 400 EMRs among 1,200 doctors. Medical communication doesn't work very well, and if we have to solve that before we can solve any of the other problems we're trying to get at.
Excellent. Thanks for the introductions. As I told you, that's a pretty amazing panel here. So what I want to do is have each of you guys sort of gaze into your crystal ball and make the prediction. You don't have to be right, but I've had this recent interest in disruptive technologies, and sort of recently was just looking back at some of those. Obviously the automobile was one. When that came along, horse and carriage. Within 3-4 years, majority of people were driving cars. Color TV. How quickly we went from people with black and white sets switching to color TV. It was just boom, right? We switched over. What are you guys' prediction for what is the next disruptive technology like that in medicine? What could switch us in a year or two from what we're doing today to something significantly different?
Well, I'm going to go first so that no one else can take my answer.
I'll go last. Hopefully no one takes mine.
There's a lot of things that you can forecast out between the 2 and 5 year time horizon that are probably going to happen, but I'll give you one that I hope happens. And that is, take your experience. I imagine the majority of the people in this room and on this panel probably have an Alexa at home from Amazon or something similar. I can envision a future where ambient computing and the concept of video and audio input in the clinic room is going to take spoken and visual data from the physician, from the patient, disambiguate that data, record it discreetly in the EHR or whatever other system to fulfill all the billing and documentation requirements, etc., but free up the physician and the patient to restore that relationship that we think has been to some degree lost in this modern age of EHR technology. I'd really like to see that come to pass in the next 5 years.
As would I, and that was mine. So you took it from me.
I win.
Yep.
I'll back down a little bit then, because I agree that this is a really interesting technology that we're all looking at. But I would say we skip the PC, Peter, that you talked about, and go directly to a device we all have already, which is the sort of mobile approach. We're not, as clinicians, using mobile devices really within our own care centers. UCSD, I think, is at the forefront of that. Stanford's doing some work, but many of the rest of us aren't very far along. But I also think that if you look at health and take the care out of healthcare, care for us is what we do in our clinics and hospitals, which is maybe 80 to 90% of our time, but it certainly isn't that percentage of our patients. In fact, it's flipped the other way. Their health is managed in their own lives, in their own homes, and without the use of the rest of us. And that's where if we can get their health and decision support and basically self-diagnosis, self-care driven to devices that they carry in their pocket and can coach them to do some things like that, I think that would be a fundamental change in what we do.
My innovation is not a technology. It's a change in the way we pay for healthcare. We all live in a world here of fee-for-service, and the number of units of service delivered keeps going up, and the cost of each one of those units keeps going up. So all the cool things that we want to do just keep making the healthcare system more expensive, and it's a system that we can't afford today. So I don't know exactly when it's going to happen, when there'll be this mega shift, whether it'll happen because of economy or politics or other. But I think it's inevitable that in the pretty near future, there's going to be a switch, a pretty rapid switch from, ponying up to the trough and still doing incremental billing, fee-for-service billing for almost everything, to much more capitated, global budget, reward for reducing utilization and bad outcomes, and it's going to be a big shift in the way we all practice. My company's actually trying to rush into that already, and I can say that it's not happening yet because sometimes we hit obstacles with those who should want to pay us that way, and they're not ready yet. So I don't think it's tomorrow, but I don't think it's too far away because I don't think that we have a choice.
Your premise is perfect, I think, because everybody here took Biology 101 and we put a bacteria in a single petri dish and watched exponential growth. And the exponential growth kept happening until what? Until you ran out of substrate, right? So the growth rate was exponential until the food dried up, and then it stopped growing. And once you cross through 22% of all dollars, you can't keep exponential growth up anymore. And I worked for Verizon for a few years after I sold a company to Verizon. And I went in with all these great ideas as an employer now with 250,000 employees about how to fix this. And I had 10 ideas that we could, next quarter, next year, lower our cost by 3-5%. We were spending $4 billion a year, one company, on our own employees' health care. And if we could lower it by 1%, that's it's $40 million right there. Why wouldn't you do that? And I had all these pretty easy things to do. And the people in charge basically said, and I was generally, I was on their peer level or above, they said, there's been people out the door and down the block every morning with ideas like that. And every year, every quarter, for 100 years, this telco, which used to be called AT&T, has increased its cost of healthcare. It's never gone down 1 quarter, ever. So this is a petri dish, and the forcing function will happen. I think we're in the big SOMO world, big data, social mobile cloud, and that world is in fact everything that you guys all said. But I think that the change is going to be even more radical than, I think we're going to move from a doctor-patient relationship to a brand-patient relationship for 90% of all interactions with the health system. It'll be blends of what you guys just said, but why on earth would you call somebody if you could get an answer on your mobile phone to a simple question? Should I take more or less of this? Is it the blue one or the red one? Should I worry about this rash? The vast majority of care, even chronic care, boils down to answers to questions that people have. We're nudging people to do the right thing. And so I think we'll reserve the consultancy part of care, which is what most of medicine is, to those tougher cases where the automation doesn't deal with it. And that companies will rise above the government din, and sooner or later somebody will figure out how to make it actually interesting and make a product that people actually want, and they'll go get it.
Awesome, excellent. Well, you guys, you've already sold mine, so I'm going to jump into some, slightly pivot. And Brian, you talked a little bit about, maybe you can talk a little bit about Green Button and sort of that theory, and maybe kick us off a little bit on sort of using our data and the data analytics and big data piece.
Yeah. So one of the things we were talking about as a group beforehand, before the session started, was things around big data and predictive analytics and that sort of thing. And it occurred to me that what we don't need is necessarily big data or even little data. We just need good data. And one of the struggles we have is that we have data but no information. So we need digital data. So one of the comments I made at the outset about the learning healthcare system, and Todd, you mentioned the concept of the green button, is using the data in your electronic health record or the data at your disposal in general to learn from previous experiences similar to the one that you're encountering now as a physician. So for example, if I have a patient in the hospital and they have a certain kind of infection and I'm deciding between treatment A and treatment B, and I go to PubMed and search the literature and I don't find a research study that addresses this question, I don't find it in any of the medical knowledge resources that I have available to me, it occurs to me that I could use analytics and data to look back in my electronic medical record for 50, 100, 500 patients in a similar situation that I'm facing and see what physicians chose to do in those situations and what the outcomes were for those patients. So I don't have a randomized controlled trial to guide me, but I have the previous experience of my colleagues and what happened to their patients. So from that standpoint, we are trying to operationalize this green button or clinical informatics consultation approach to try and learn from that which has gone before and has been recorded in the system to guide how we do things going forward. And in this way, we move down the road towards a system where every patient that comes into the enterprise, that comes into the hospital, contributes to the learning, and we make it iterative, and we gain knowledge in that respect.
Peter, any additional comments? I know you're really focused on getting the data, and a lot of organizations aren't as lucky as maybe UC San Diego or Stanford.
I think your green button idea is going to be the new librarian, don't you, or something like that? Because you're not, in the end, once that, you mentioned in the other room the question of somebody with cirrhosis and whether or not to do what with them.
Oh, to do venous thromboembolism prophylaxis.
Yeah, so whether how you're gonna thin their blood or not, because they have clotting problems already, and it would be good to fix that, but you don't know. But yeah, and I had one of my companies had 10 million patient records from 10 million patients, which are all dictations, and we had a pharmaceutical company that was trying to get a label changed because they claimed that their drug didn't have the same side effect as their competitor's drug. And I said, well, that's easy. I'll just look at my patient records from 10 million patients and give you the answer. They were going to spend $22 million on a study that we actually answered for them in under a week by merely looking. And this was not structured data. This was text. This was dictations. And I am really, one of my passions is I think we made a big mistake in forcing structured data everywhere. And the result has been that we got faxes everywhere. It would be better to have digital data everywhere, even if most of it's text. There was a study that came out that showed that looking for complications and data from the VA, where you tried to do analytics off of the structured data in the EMR versus the free text data from discharge summaries. And they got better alerts on the free data from the discharge summaries than they got from the structured data in the EMR. And there's all kinds of reasons for that. But people depend on the unstructured narrative data to do their thinking and to get the subtleties. And getting the subtleties right is what medicine is all about. And putting things in columns and rows isn't all about subtlety. So there's a conflict there.
Okay, I'm going to be kind of the contrarian or low-tech guy one more time. For me, big data is not more nuanced data in the hospital. It's accessing a lot more profile of the patients out in the community. For example, my population, I really want to know who has the highest likelihood of being readmitted. I can use things like a LACE score, which is information from the prior hospitalization, which tells you something about the prediction of whether they'll be readmitted. But what's really more important than which conditions they have and how long they were in the hospital is what does it look like in the house? Who's taking care of them in the house? How competent are they to take care of themselves? What kind of food do they have in the refrigerator? That's not in the LACE model. That's the kind of big data that I want. In addition, a lot of my patients happen to be Medi-Cal. Medicaid patients. And they're in and out of all kinds of social services. So this whole notion of social determinants is huge for us. And having links to other sources of information is extremely important, both to be able to interact with those other service providers and to be able to predict what the needs may be, so that we can do a better job of taking care of them. So there's another component to big data that maybe spans laterally and wider, as opposed to the deep, really irrelevant deep stuff that you guys have been talking about.
Yeah, I would agree completely. And it's this piece that, I think this is why there's a lot of interest in IoT. But I think just to the simple fact of, there's a ton of missing data. That's why our models often fail, is that they're just missing all of those in between those visits. You got an interesting, Rick, with a new medical school. Can you talk a little bit about sort of some of the things that you guys are thinking about? Starting fresh is sort of an unusual position to be in.
I think it is unique. I mean, Kaiser and a few others are doing new medical school. Geisinger has one that they're putting together by acquiring a medical school. But for us, it's interesting. We're with a tier 1 research institution, so it's phenomenal. We're like a UC or a Stanford in terms of the undergraduate campus and graduate schools we have to draw on. But we're greenfield in terms of a number of things. Our payment model in Austin is fee-for-service. There isn't a lot of managed care there. We don't own our own hospital. Our hospital is just Ascension, and we have another partner through HCA. And so we have to decide, are we going to build a academic medical center? Are we going to build a traditional model with a large hospital and clinics and things like that? Are we going to build something with the community docs and try to integrate a different way of care, or look at different models, look more at post-acute care? So it allows us to do some things that are a little different, innovative, sort of educational side, but on the data side, we're concentrating a little less on clinical data because we don't have so much right now, and more on the social determinant side. So we have projects to collect a lot of this additional data from the community and feed that back to the community docs, so that they can, and care providers and others, so that they can actually do things that they would not be able to do just with the clinical data that they have. So I think it gives us a green field, which is both positive because we can do anything, but a little scary because what we don't want to do is build up something that's economically not going to be viable, but at the same time, we have to be economically viable as an institution. So it's really an interesting time with the payment changes and other things like that that we'll discuss.
Excellent. Brian, any thoughts on how medical school, we were talking about how old school it was when we went through, and have you guys seen pivots? I know on our side we've been trying to pivot more video, flipping the classroom, other things that you guys you're tackling?
Yeah, so we've certainly evolved at UCSD from the old school model of, 2 years of medical school in the lecture hall and then 2 years out in the clinical space, to have that be much blurrier in terms of those lines and getting students clinical experiences right out of the gate. Where we're going now in terms of educational innovation at UCSD, and I see this at other medical schools, is to do more of those kind of things that you suggest. The lectures on video and less in person, more small group learning, more case-based learning, more simulation, both in terms of a patient simulation lab, as well as simulated patients in the electronic medical record. One of the things that I think that is not yet universal around medical education is training medical students on what they're going to face in terms of documentation requirements and the regulatory space they're going to inhabit, and the kind of vendor products they're going to encounter, mobile technologies and all of that. We're training them on the basics of medicine, but we're not training them in the practice environment as much, and so we're looking to make some changes there as well. I want to go back to the social determinants thing and the Internet of Things that Neil and Rick mentioned, and that is going back to the concept of big data versus good data. I'm going to be a little contrarian here, and I'm a little cautious about bringing back a whole bunch of social determinant data to the point of care of the clinician, because putting on my doctor hat for a minute, I need to know what to do with that. So you can tell me your patient lives near a food desert, or there aren't very many community resources near where your patient lives. And that's important information to know, but what we're going to have to lobby for in our technical roles is to make sure that our operational colleagues at our organizations also provide us with the staffing and the resources, or the conduits to get our patients the interventions that they need in response to those. So do we need more social workers? Do we need more case managers? Again, a non-technical intervention, but something that's just as important.
Maybe I could just address that one second. We see that as well. One of the things is, do you give a bunch of additional data to the provider, or do you give them a risk score? And providers are looking for risk scores. They're looking for how much should I worry about this, and should I dive into more data, or am I pretty comfortable because everything is in pretty good stead here. The other is trying to deal with the readmission side and the post-acute side of it, which is when we, and I think your point is key, if the admitting ED doc or the hospitalist who's discharging the patient has an idea where they're going, and they're going to send them back to their car, or send them back to a home where the EMS has already seen is not a place that they're going to recover from, then that's something that we should provide at the point of care if we can, so it's part of the decision making. And then the other side of it is, and we're looking at this in terms of cognitive impairment, we're doing a lot of damage to our cognitively impaired patients when we admit them and operate on them and put them under anesthesia for common things such as fractured hips or things like that as well. So can we provide some alert to the ED and hospitalists as well, and the operating surgeons and anesthesiologists, to avoid bad outcomes early on in the process? So this is where you have to be careful, and I would agree with you, Brian, not do data overload, but can we pick certain pieces of data that we wouldn't have at the point of care, get them to the point of care, so when we actually interact with this patient and either admit them or discharge them, we actually do the right thing.
Your point. Yeah. I'm actually going to go one further back and take on Brian's point where you aptly said, just because we know about it doesn't mean that's going to solve the problem. We need the operational solutions in place. And that speaks to why I chose changing the payment model. Because when you change the payment model, everything else flows from it. Of course we're going to have a social worker, of course we're going to have food delivery, of course we're going to be helping them find a safe place to live, all those kind of things, because otherwise they're going to be back in the emergency department and readmitted to the hospital. And we're the final receptacle for all that, and we're going to be paying that bill. So I completely agree with you that we need to build a model that utilizes data to predict who's going to need things and to know what they're going to need so that we have the right resources available, but that also pays for it. It's all enmeshed, it all works together. So yeah, I agree with everything you guys said.
So I'm going to pivot a little bit, and we're going to take questions in a few minutes here, but pivot a little bit and get you guys maybe a little off guard. So, you know, I see increasingly my faculty and lots of researchers are just at a conference where we're presenting all of these great machine learning models that they've built, and they're all pulling it off of EMR data that they've been collecting out of the EMR, and they're like, oh look, I can predict who's going to cancel on this day. I'm going to use weather data and other things. I want to kind of push and say, well, should they be really looking just at the EMR data, or should they be really looking at more data, and should they be looking at how do they collect the right data to do predictions? Let me get you guys' thoughts on that.
Well, so the easy answer is, of course, if it helps improve the model. So
But how do you pull it off?
Well, so I have a LACE Plus score on all of my patients. What I've learned is that, maybe this is a vagary of UC San Diego, all of my patients are high risk for readmission. So it doesn't really discriminate in terms of how I treat the patient, but maybe we need a better model to come along with social determinants and all that kind of thing. I wasn't trying to poo-poo the concept of that earlier. The literature shows it probably 4 to 5 times the impact on a readmission rate as anything we control within the 4 walls of the hospital. So I think that it is incumbent upon us to look for additional data sources outside of the clinical data in the EMR, because I strongly believe it's going to inform our decision making. And so much of what is going to happen to a patient is driven by their environment and the encounters they have outside of the clinical realm. I think that we're just starting to learn about what those good data sources might be with the concept of social determinants of health, patient-generated data, et cetera. I think in the next 3 to 5 years, we're going to learn where the levers are. I don't think it's known yet.
So Neil, you're diving into this, but I'm sure it's kind of tough, right? Getting people to pay for this and getting the data back in, and who should be building the models?
And how do you scale? How do you make it
scale?
national?
Yeah, that's the hardest thing for us, because we're a service business, and service businesses are very difficult to scale. We're plucky. We have a lot of moxie, but it's not easy, and we're constantly inventing and reinventing all of our own processes. So it's very tiresome to try to figure it all out. I was telling these guys earlier that yesterday I see patients on our platform. I saw a woman who lived in her car. I did the visit in her car, and she had a lot of medical problems. But the first thing we had to do was help her figure out how she was going to get out of the car and into some place where she could live. Because I don't think she's ever going to be able to do her finger sticks in the car. And she couldn't even find some of her medicines in the mess that she had in the car. So that kind of gives you some insight about just how rock bottom some patients are. And when we think about sort of the clean, gleaming hospital and how we have complete control over everything, it's just totally the opposite for a lot of people. And so Todd, when you ask the question, so where's the data? The data is going to start really crude and really simple. Some very basic questions about where are they? Do they have food insecurity? Are they in a safe home? Do they have a caregiver? Do they have enough memory to be able to follow their medications? Really basic blocking and tackling stuff. Before you get into nuances of their MELD score and their ejection fraction and or their blood sugar, HbA1c 7.2 or 6.8. We usually will take either one of those in our patient population. So there's a lot of.
But you get paid more under ACO world if you do get 4 A1Cs a year and a written eye exam a year.
Well, you won't lose money if you hit your quality indicators, but really in most ACO worlds, both federal and commercial, you're going to get a proportion of savings. So unless you make the savings, it doesn't really matter what your quality scores are. But you have to hit the quality scores too. That's sort of secondary. Yeah, but they're all important things. We actually do a lot of tracking of all those clinical quality things so our providers know and can click those things off as they're doing their business as well. But that's not for a lot of our patients, that is not what we're going to be dealing with for the first 3-6 months when we're helping them try to stabilize and get better.
Besides central payment or single payment or payment reform or whatever you want to call it, is there a step before there that will drive value out to the very end point?
Yeah, not hogging the conversation too much here, but there's sort of a sequence of payment models from pure fee-for-service here to completely globally capitated over here. And ACO is, I don't even think in the middle. It's a stepping stone, and there's lots of different ACO models. So there's upside only, which means if my delivery system does well, I get a bonus, but if we don't do so well, we don't lose anything. Then there's upside downside risk. Then there's, does that sit on top of a fee-for-service model, or does that fit on top of a physician services capitation model? Do I then take hospital capitations? There's a whole sequence of different ways of doing it. Probably the first step out of fee-for-service is fee-for-service with a care coordination fee, so that you have enough resource to start implanting things into the delivery system to start helping.
So one of the issues is sort of the uptake, though. I mean, will the patients, it's one thing to pay a nurse to go out there and collect the data, but there was a lot of discussion, I think there was a panel before, talking about, well, we've gotten patients to, or we've gotten people to, they book their own reservations now, Airfly, no one calls for travel agent anymore. We've just enabled them and they just do it. And they've taken over a job. Do you guys see a future where, essentially people are doing what the nurse's role was, which was collecting that data, getting their blood pressure, getting their sugar, putting it all into a system so that we can just sort of mine it? Just love to get any thoughts on that.
The risk we see with that is that, say for example, Fitbit data, the studies that show, or Fitbit-like devices, the studies with using that for weight loss show that there's no great benefit to that. People wear them for a certain period of time, they lose a little bit of weight, but then they gain it back. And cognitive behavioral therapy or traditional weight loss is more effective. We know that in non-insulin dependent type 2 diabetics, the tracking their blood glucose has no effect on the hemoglobin A1Cs. So they are, even if they are tracking it, are we having a benefit? So I think it goes back to the issue of what, we look at all of our data, but the real question is, what data are we not collecting? That would be of greater value than all the vast reams of data that we could collect perhaps.
The other difference between medical data or clinical data and doing something like booking your own flight or making a reservation at an open table is that sometimes those data points need a little bit of clinical interpretation or need to be gleaned by somebody with some degree of training. So we could have internet-enabled devices that can take a weight or a blood pressure or something like that, and that's all well and good. But to ask questions about certain aspects of a patient's clinical history or symptomatology may be something where you could have a questionnaire that's standard, but it wouldn't necessarily get at all of the types or the nuances of the data that we might need to make the maximum impact. You would need someone with some clinical training to be involved. Now, finding the balance, I think, is an opportunity. Right now, we have a clinician, oftentimes a highly paid clinician, doing all of that stuff. And could we move some of that to some automation? Absolutely, I think.
Well, titrating meds for glucose control or bleeding control or, blood pressure control this is a huge resource cost, and all of that should be automatable for 90% of users. Maybe it's 80%, but it's not. It's certainly not 100%. But the entrepreneurs of the world with a little bit of extra help should be able to create machines that just do that, and they do it so well that they save so much money that the hospitals and the deliverer people, if they're in a capitated world, would prefer that, right?
That makes sense, but for me,
It doesn't solve all problems. It just takes one slice of the problem set and saves the harder part for the doctors.
Probably the biggest opportunity in one disease to have a physiologic parameter that you should be able to track and dramatically improve outcomes and reduce costs is weight in heart failure, okay? And there have been some positive randomized trials that have shown that, and there have been other trials that have failed.
Yes.
And to me, the two characteristics of the successful trials are, number one, that the person who is receiving the weights and reviewing the data is embedded in the delivery system. They're not in Phoenix or some other place and then shooting a fax to an office as some, independent third party, but that stuff all just goes, it's a fax, you got it right,
Yep.
and then it goes right in the garbage. It doesn't get acted on. But if it's like a nurse care manager or it goes to the heart failure expert on the team, then it gets acted on. So that's the first thing. It has to be embedded in the team. The second is, these trials, if they think of heart failure as a siloed disease, that you only have heart failure, it's pretty rare that somebody had a dilated cardiomyopathy out of bad luck from a virus and they only have a heart failure for that reason. They probably have hypertension, they probably have diabetes, they probably have had a couple of MIs, throw in some COPD just for the heck of it, maybe renal insufficiency and liver disease. So they may not get admitted quite as often for the heart failure, but they're going to overall get admitted just as many times. So unless you put it into the context, both in the delivery system and the whole person, it doesn't really work. So that's the challenge of making these sort of automated systems smart. I think the early versions weren't that smart, and people like you are going to make them smarter.
No, I think you're trying to make them work in all cases where the problem is. If you'd say, I'm going to worry about the 50th percentile of people that have simpler cases, we need to get to public questions here. Because there's people jumping up and down.
Yeah.
I can see people holding their hand back.
So let's move to questions. There's a microphone coming to you, so.
I'm Jack Mormon, U.S.-Japan MedTech Frontiers. So I'd be interested in your comments on this radical, to me, new to me, idea of the virtual hospital, the Mercy virtual hospital that's in St. Louis. And recently I saw that a startup got $4 million, Mobility Home, I think it's called, that says they're a virtual hospital. So this is patients not in the brick and mortar of a hospital.
Chatting a little bit, who wants to take
Well, I think in all fairness, Kaiser, for example, and other fully capitated plans have been doing that for a long time. You have to almost be dead to get into the hospital. I'm being facetious, but they've pushed a lot of that acute care out, and I think all of us have seen a pressure across the board. So all of our acute care facilities, when we were residents, we were treating patients who we now treat in the home. I think if you look at what Intermountain is doing, I think UCLA we talked about a little earlier today, the idea is to push the care out and use other facilities and eventually not have as many facilities overall. One of the biggest things is how do we in this country probably get rid of a third to a half of the hospital beds that we currently have and provide the same level of care but bring our costs significantly down, because that's where we know where a lot of our dollars are going. So it's going to happen, and the question is how fast and who's going to do it.
Few threads. One is hospital at home is a well-known concept now. Came out of the folks at Hopkins, where they give people a choice of when they're in the emergency room about to be admitted. Do you want to be admitted to the hospital, or would you like to go home and we'll bring the IV poles and the nurses and everybody to your home? And it turns out if you look at the trials, randomized trials, people do equally well, except they enjoy it better and they get quote-unquote discharged from the hospital faster when they're at home because it's just easier, they're already home. So it's a very viable model, and there are now multiple hospitals around the country that are doing that. So that's sort of hospital at home already. But what you were asking, the Mercy Virtual, is kind of interesting. I actually saw those guys at the American Telemedicine Association meetings, and I was surprised it wasn't more that they were doing yet. A lot of the stuff, it sounds really cool, and they got their big center. There isn't that much that's going on. There's a lot going on in stroke care all across the country. I think Stanford's pretty big in that. But there aren't that many use cases that are really happening, and it seems to me the biggest thing that a lot of hospitals are trying to do is to get more business into their hospital. They're using the telemedicine as a way of getting community hospitals to refer to them. So it's more of a business opportunity than it is a real true virtual thing yet. But I think we're going in the direction that you're imagining. It just might take us a little while to get there.
So, question there.
Arthur Keller, Psychoanalytics. I heard you talk about big data. I heard you talk about good data. I'm wondering if you could talk about clean data. I went to the doctor some time ago, and they weren't sure what the diagnosis was, and then they've tried different things, and then eventually I got better. The old diagnoses are still in my chart. And so if you're going to be basing my health on the old diagnoses that weren't right, you're going to probably make the wrong decision. So how do you make decisions and make sure that you are making decisions on good, clean data?
Adding computers makes that worse.
Yeah.
I completely agree. The concept of what we call chart lore is that which persists in the chart over time, whether or not it's still accurate. I agree, computers make it easier to add than to subtract, as does normal human nature. I don't have a technical solution for this. This is something where something that we didn't do in the migration to the EMR platform in general is teach users how to do the gardening and weeding that is necessary to keep things up to date and to make that a priority and to carve out time to do it. It's all too easy to just add another diagnosis.
This is largely why doctors prefer discharge summaries than to chart review.
That is exactly correct.
Because what we prefer and what is least available of all the records is the narrative record. It drives me crazy. And that drives most doctors. One of the number one reason that doctors are jumping off the roof is doctors prefer the narrative because the other doctor thought through some of the question and had some thinking about it and came to some conclusions and documented their conclusions. The nuance matters more than the data itself.
Hi, Simran, and I have a couple of addiction and psychiatric clinics, but I'm interested, thank you so much for speaking today. I'm interested, and you talked a lot about social determinants, and there was a debate earlier today about the roles and responsibilities of physicians. And so I'm curious to hear your thoughts, particularly as you're looking at your institutions and your employees. Where does the role of physicians start and stop when it comes to helping with social determinants and the other things, and how that actually integrates into what you're looking at in terms of not just the health outcomes, but you've also got to be concerned with your revenue outcomes too?
Well, for us, we have the unique opportunity in our clinics and even in some of the acute care settings to basically build those teams as one. So we have physicians, social work, behavioral health, and physical therapy all on the same teams. So we basically can see the patients, and whoever the appropriate provider is can be right there to see them. So the providers come to the patient rather than the patient being sent around to various different things. And on the behavioral health side, we have Steve Swarkowski, which is our chair of psychiatry. We have the opportunity to take the state mental hospital, which is in Austin, and instead of rebuilding it, break it apart. So we can build facilities all over the city, take an institutional view and break it up, and really start from ground zero looking at that, because behavioral health has to be a key component in every one of our care sites. So if we can push it out there instead of consolidating that, that's one way to address that.
Somebody on the panel, I think you were on, said doctors don't want to know about social determinants of health. And I don't think that's right. So
I don't think that's right either. I think they don't want to know about it if they're powerless to intervene.
If they can't do it.
Yeah, I think the role of the physician is several. One is to screen, to have your antenna up so that you're seeing marks on somebody's body, emaciation, poorly kept in the way they present themselves, not showing up, alcohol, breath, all those things. So you're asking questions and you really just are trying to tease out what may be going on, and then in a very humane way, sort of probing deeper. but then utilizing resources you have access to address those issues. Medical school, we're not really, at least when I went to med school, we weren't really well trained to do that kind of stuff. It's out of our hearts, compassion that we're trying, but we don't have the skill set, we don't have the time allocation. We need people to help us, and so in my company, we've built that kind of a team. It sounds like, Rick, you're doing the same thing, but I don't think it's the role of the physician, it's a poor use of the physician's time to expect the physician to then go and solve all those problems. You just have to put the right resources.
But if you're projecting, wouldn't you imagine a primary care provider of the future would get down in those weeds even more? That it might be a blend of physicians and PAs or whoever it is that can get their head around the bigger problem and try and do some interventions in those spaces.
Yeah. I mean, like, so in my company, the nurse who's in the home is looking around and seeing if there are fall risks, if there's food in the refrigerator, if there's a problem with clutter, bed bugs, things like that. So they're seeing that. That's kind of in the weeds that you're talking about. I don't really think putting a doc directly into the home is very time consuming. Yeah, it's using the right person.
Well, I want to thank everybody. We're out of time. I know there's another question over there. If you want to come up afterwards and chat with us, we'd be happy to. So, thanks to the panel.